الكوادر الشابة في النيوكلير ميديسن، وهي هتقدم لنا النهارده يعني مجموعة هايلة من كل حالات البريست كانسر اللي قابلتها خلال رحلة العمل في البيت سي تي. فتفضلي يا دكتورة هبة، المحاضرة هتبقى بريست كانسر How does PET-CT help?
Good morning, dear professors and colleagues. Thank you very much for giving me this opportunity to share in the annual scientific conference of Ain Shams University Radiology Department. My talk today is about breast cancer. How can PET-CT help? As we all know, breast cancer is the most common malignancy among females, and it might be inherited or sporadic. We know that there are different modalities that can diagnose breast cancer, like mammography, ultrasound, MRI. PET-CT is one of the leading diagnostic tools that can help in many ways. We can detect the primary diagnosis, the metastasis detection of a case presenting with mets of unknown origin, double primaries, post-operative and post-therapy follow-up, routine follow-up after treatment completion, residual and recurrence. We'll review some real cases from our practice to elaborate the role of PET-CT in breast cancer. Start with case number 1, and a 56-year-old female patient presenting with left breast lump. The ultrasound revealed suspicious lesion, mostly malignant, and referred for PET-CT assessment. As you can see here, the CT images and the fused PET-CT images reveals left breast, upper outer quadrant, deeply seated, metabolically active, soft tissue mass with speculated margin showing features of being neoplastic, associated with reactive skin thickening of the left breast. And here you can also notice the thickening of the axillary crease next to the breast mass, which is thickened compared to the other side. And it's not avid, but it can be reactive or infiltrated. But we have to mention it in the report. What PET-CT added over the sonomammography is that this patient had also a metabolically active marrow lesion, completely not visualized in the CT because it's still a very early osseous, it's marrow lesion. It was only evident in the PET images. So this is a case of left breast cancer with metastatic osseous, marrow deposit. In case number 2, a 37-year-old female patient, known case of treated left breast cancer by conservative breast surgery, as well as chemo and radiotherapy 2 years ago. And she was free since then and referred for routine PET-CT follow-up with no recent complaint. We look at the MIP images, it's completely clear, nothing to comment on. And the primary side, there is low-grade metabolically active periareolar thickening of the skin, which keeps with post-operative and post-therapy sequelae. There is no recurrence. However, when we lowered the FDG avidity of the brain parenchyma, we could see that there are two well-defined metabolically active space-occupying lesions with surrounding vasogenic edema at the larger one. And as you can see, the one seen at the left occipital lobe was not clearly visible in the non-contrast enhanced CT, but the metabolic activity was evident, and this was a case of metastatic breast cancer with brain mets. In case number 3, a 75-year-old female patient newly diagnosed with right breast cancer and referred for PET-CT assessment. The initial PET-CT revealed a large right breast mass with metastatic ipsilateral lymph node and unfortunately an osseous deposit. The patient received chemotherapy and referred for follow-up after 3 months, and you can see there is no change in the mass. However, there is complete metabolic clearance and morphological regression of the axillary lymph node as well as the osseous lesion. However, unfortunately, the patient developed a new metabolically active right axillary lymph node that was not infiltrated in the initial scan. In case number 4, a 51-year-old female patient newly diagnosed with left breast cancer and referred for PET-CT assessment. As you can see in the fused and the CT images, the mass is of low-grade metabolic activity. And note in image number 3, the fibrous band extending to the nipple areola complex with minimal nipple retraction. Note also here, we also noted that there are innumerable lytic osseous lesions randomly distributed in the axial and appendicular skeleton. Most of them were metabolically inactive, which elaborates the idea of the metabolic signature. The tumor is of low-grade avidity, as well as its metastasis will be of low-grade avidity. So you have to look be very careful with tumors with of low-grade, insignificant avidity or no avidity. Their metastasis will follow them. So you have to look carefully at the CT images in order to pick them up. If you just focus on what's FDG avid, you are gonna miss a lot of lesions, and this is a fatal mistake. In case number 5, an 80-year-old female patient presented with left breast cancer. The bone scan was reported free, so she was referred for PET-CT assessment. Here is the left breast mass, a big mass with the ipsilateral lymph node. But what the PET-CT added is there are 2 non-FDG avid osseous, completely lytic osseous lesions at the left iliac bone. The reason why they did not appear in the bone scan, because all of you know that the bone scan depends on the osteoplastic activity. So these lesions are completely lytic. They lack the osteoplastic activity. That's why they were negative in the bone scan, but of course they appeared in the PET-CT. And again, they follow the metabolic signature of the original tumor. They are of low-grade avidity. Case number 6, 46-year-old female patient presented with history of left breast cancer, underwent mastectomy, received chemotherapy, and referred for PET-CT assessment. The first post-operative image, you can see there is a low-grade metabolically active, ill-defined soft tissue sheet in the mastectomy operative bed. Now, this is most commonly is reported as post-operative changes, however, for close follow-up. Why? Because we have no idea what was the metabolic signature of the primary tumor. Was it of high-grade avidity or low-grade avidity? We don't know. So we report this and say it is most probably post-operative changes for close follow-up. 3 months later, and no treatment was received. As you can see, there is decrease in the metabolic activity and the size of the fibrous tissue, as well as the stranding of the surrounding fat planes, which keeps being benign in nature, and no underlying residual tumoral tissue. The same for this patient who had conservative breast surgery and referred for PET-CT assessment. See at the upper outer quadrant of the right breast, there is a mass-like lesion of low-grade metabolic activity, most probably post-operative, and which is confirmed in the close follow-up 3 months later. There is reduction in the size and in the metabolic activity of this lesion, which keeps with post-operative fibrous changes. In this case, a 64-year-old female patient newly diagnosed with left breast cancer underwent recent lumpectomy and referred for PET-CT assessment. And it's recent lumpectomy. See, the post-operative seroma is big and of high-grade avidity. It's a cystic lesion occupying the outer quadrant of the breast and the axillary region with skin thickening and show increased metabolic activity. This was reported as post-operative seroma, again for close follow-up. When we followed up, there is a reduction in the size and activity of the seroma. However, unfortunately, the patient developed a small right-sided lymph node. Note in the first image, there were no lymph nodes on the right side. They were very tiny. Here, they are still tiny. However, one of them has grown much bigger than the initial scan with high metabolic activity, and unfortunately, it was metastatic. In case number 9, 43-year-old female patient presented with history of left mastectomy and referred for PET-CT examination. Again, as you can see, there is linear metabolically active soft tissue band, which keeps with post-operative change, but the worrying thing was the subpectoral lymph node, when in the 3 months follow-up, there is complete resolution of the seroma as well as complete resolution of the subpectoral lymph node. So there was no underlying residual malignant cells, and it was only post-operative changes. Case number 10, 64-year-old female patient presenting with left mastectomy and treated left breast cancer 6 years ago, referred for routine PET-CT examination. Unfortunately, we can find a very small lymph node on the contralateral side, very small in size by CT, not suspicious by CT, but metabolically active in the PET, and unfortunately, it was also metastatic in nature. In this case, a female patient presenting with history of right breast cancer. This is the initial scan, and the breast cancer, is, as you can see, is of low-grade FDG avidity in a dense breast. The patient received the chemotherapy followed by PET-CT assessment. As you can see, there is complete metabolic clearance of the primary lesion. However, at this scan, we reported that there was slight increase in the marrow activity at the left femoral shaft. It was mentioned for close follow-up. However, based on the metabolic clearance of the primary breast neoplasia, the patient had MRM and referred for another follow-up after 3 months, where no treatment was received in this period. Here, the post-operative mastectomy changes. As we've seen it before. However, unfortunately, the patient started to develop different metastatic deposits. As you can see, the osseous lesion, the marrow lesion, has now developed into a well-settled osseous lesion with very high metabolic activity, as well as subcarinal lymph nodes and metastatic hepatic focal lesion. In this case of 72-year-old female patient, newly diagnosed with right breast cancer and referred for PET-CT evaluation. In the PET-CT, we can see there is a large retroareolar ill-defined mass with high metabolic activity. But what the PET-CT added more is it's not this mass only. There are multiple satellite lesions hidden within the breast parenchyma. It's a case of multicentric breast neoplasia with regional ipsilateral lymph nodes. Also, there are multiple skin nodules as well as left internal mammary lymph nodes. So it was not only the retroareolar mass, it was multicentric breast neoplasia with skin nodules and internal mammary lymph node. In a 39-year-old female patient presenting with right breast mass by sonomammography and pathologically proven to be ductal carcinoma, referred for PET-CT assessment. Here, as the sonomammography findings, we could find a left upper outer quadrant, right breast lesion, and the ipsilateral lymph node. What the PET-CT added was that there are 2 more metabolically active nodules seen at the same quadrant of the right breast, and it was not only a single lesion, there are 3 lesions at the same quadrant. It's a case of multifocal breast neoplasia with ipsilateral lymph nodes. And in the other case, 60-year-old female patient presenting with right breast mass, pathologically proven to be invasive ductal carcinoma, again referred for PET-CT assessment, and the sonomammography also stated that there is a left retroareolar lesion that was not biopsied. Here, the PET-CT fused and CT images. The lesion, it's not a single lesion at the right breast. There are 2 ill-defined lesions associated with reactive skin thickening and ipsilateral axillary lymph nodes. The left breast mass was also metabolically active, and note Bardo, again, the thin fibrous band extending to the nipple areola complex. Histopathology also revealed the left breast mass to be neoplastic in nature, and this was a case of bilateral breast cancer. Let's go with a 65-year-old female patient presenting with right breast mass by sonomammography, proven to be lobular carcinoma, and referred for PET-CT assessment. Look here at the lobular carcinoma. It looks by CT and PET criteria an acute lesion, actually. It's well defined, of low-grade metabolic activity and no speculated margin, no edema, no skin thickening. However, this is a lobular carcinoma. What I want to say here is that it's of low-grade avidity. So look carefully at the PET-CT, searching for mets that are of low-grade avidity or no avidity at all. And unfortunately, we found a small osseous deposit at DV12 vertebral body that is not metabolically active. Note the high activity of the surrounding bone marrow. This is bone marrow, this is hyperactive bone marrow. But the osseous lesion itself is non-FDG active. If you don't look carefully at the CT and focus on the metabolic signature, definitely you will miss this lesion. In a 63-year-old female patient presenting with left breast mass and left axillary suspicious lymph node by ultrasound. What we can see here is the retroareolar breast mass with speculation showing suspicious features in CT and PET-CT. Then the lymph node that was suspicious by ultrasound. However, the lymph node here is non-FDG avid. Should I report it reactionary or should I be worried about lymph node? Actually, you should be worried because it's enlarged and it has indistinct hilum and cortical thickness. 3 suspicious features by CT criteria. Adding to them, it was suspicious also by ultrasound, which is more accurate in assessing the lymph node features or shape than the CT. So this lymph node was reported to be potentially malignant. Why is it not FDG avid? Maybe because the amount of malignant cells inside the lymph node are still not that high to localize the tracer that much. But maybe if it's left and in the follow-up, we will find it metabolically active. So it was reported that it is a potentially malignant ipsilateral axillary lymph node. Let's proceed with a 23-year-old female patient presenting with multiple innumerable osseous lesions and referred for PET-CT assessment, searching for the primary lesion. And sonomammography, specifically in this patient, was reported free apart from bilateral fibroadenosis. Here are the widespread metastatic osseous lesions. In the breast images in the PET-CT, we could find that there is an very faint soft tissue lesion in the left breast, deeply seated, hidden within the dense parenchyma of the breast. In the CT, you can miss it very easily, especially if it's non-contrast CT, where you're gonna miss it. But in the PET, it's evident and metabolically active. Adding to this, there is a left internal mammary lymph node as well. In the next case, 55-year-old female patient also presenting with bony aches, and MRI revealed multiple osseous lesions. Again, we can see the metabolically active osseous lesions as well as intercostal and pleural nodules. And here is the primary malignancy, and it's not only a single lesion, there are few satellite lesions in different quadrants, so it's a case of metastatic multicentric breast neoplasia. Here you can see the multiple lesions, not only in the parenchyma, but also at the skin, the skin nodule. So it's a case of metastatic multicentric breast neoplasia. In the next case, 26-year-old female patient presenting with history of left breast cancer, to which she was submitted to surgical resection followed by silicone implant insertion and referred for the routine PET-CT assessment. Unfortunately, again, we find a metabolically active soft tissue nodule just medial to the silicone implant, and this nodule revealed to be neoplastic in nature. It's residual tumoral tissue. In the next case, 44-year-old female patient presenting with history of treated left breast cancer. The prior PET-CT following the treatment of the left breast cancer was free. And the recent sonomammography only revealed dense breast parenchyma bilaterally and left breast post-operative and post-therapy changing. Nothing to worry about. So she was referred for the annual PET-CT later on. In our PET-CT, at the right side, it's dense breast parenchyma, dense glandular tissue with no definite FDG-avid lesions. However, at the left breast side, we can see the post-operative changes, but add to them, there are multiple FDG-avid parenchymal nodular lesions hidden within the dense parenchyma of the breast and within the fibrous tissue of the prior breast surgery, and this is a recurrent breast cancer case. In the last case, a 74-year-old female patient presenting with recently discovered pelvic mass, pathologically proven to be gynecological neoplasia, so referred for PET-CT staging. Here in the pelvic images, we can see a huge mass that includes the uterus and both adnexa, mixed solid cystic soft tissue mass occupying the whole pelvic cavity. As we proceed, you can see how big is the mass. It's also associated with multiple peritoneal and anterior abdominal wall deposits. As well, one of the deposits is herniating at the inguinal region. But what the PET-CT also revealed was this. This is right breast, lower central quadrant, metabolically active soft tissue mass with ipsilateral axillary lymph node, and this was also pathologically proven to be neoplastic in nature, and this case was present double primary, gynecological and breast cancer at the same time. My take-home message is PET-CT is mandatory for proper assessment of the neoplasia prior to intervention, whether it's surgical or therapeutic. PET-CT is an excellent tool for picking up the tricky lesions, assess their site size and their metabolic behavior. Non-FDG-avid primary tumors and their metastatic lesions may be missed if we only depend on the PET-CT images and neglect to search and look carefully at the CT images, especially on those with no FDG avidity or low-grade FDG avid lesions. Thank you.
Thank you, Dr. Heba. بشكرك بس Thank you. This is very interesting and very good cases and very interesting cases. يعني next talk يعني I will be كمان interested إن يبقى في imaging للclassic imaging للبريست والPET CT imaging عشان دي هتدينا more context على ازاي الاقي الديفرنسز، يعني ازاي اعرف benefit اكتر لما يكون معانا كمان الايمجنج اللي هي الماموجرافي MRI ultrasound. So this will be your talk is perfect. It's perfect. بس يعني لو عملتي دي كمان هتبقى احنا كاونكولوجيست هنبتدي يعني يبقى في اغراءات اكتر يعني. Thank you. So our next talk